I'm going to go on to our next speaker, Dr. Fathima, who's a medical consultant, pediatric and ophthalmology and adult strabismus services from Arvind Eye Hospital, Tirunelveli. On to you, doctor. Can you share your presentation? Yeah. She's going to be talking on ectopia lentis.
Yeah, coming to the topic, ectopia lentis management. It is the malposition of the natural lens caused by defect in ciliary zonules. So how do we manage? First, we have to pick up the early sign of subluxation, that is progressive lenticular myopia and astigmatism. It occurs because of the zonular disruption leading to increase in lens curvature and tilting of lens. And even otherwise in Marfan syndromes and other syndromes, it can occur due to long axial length. So mild subluxation, we have to carefully note in SITLAM the clear space between iris and lens. Some even advocate three-piece gonio mirror to find out the space between the lens and iris. Only if we pick up that ectopia lentis, we will look for this ocular association and particularly the systemic associations. Among the list, Marfan is the first common and isolated ectopia lentis is the second common. And disorder like these are will cause more neurological problem even in the infancy. So only these may present to us for the first time. So about Marfans, we have to diagnose based on the revised Ghent criteria, where with the presence of family history, it is quite easy to diagnose. In the absence of family history, one has to rely upon the echo finding, particularly of the aortic orifice. More emphasis is on the aortic orifice dilatation. The Z score, it is nothing but the calculation based on the pediatric normative data according to the child's age. And it is very important to know about this ectopia lentis syndrome also, because when the echography is normal, we may label it as isolated ectopia lentis, but it could be ectopia lentis syndrome if there is FBN1 mutation. Since our patients, all the patients will not be affordable for genetic analysis, this is the practical difficulty to differentiate between ectopia lentis syndrome and isolated, because even this has cardiovascular risk. Every visit, it is important to document the type and amount of subluxation following any type of grading, so that we will find out the progression of the subluxation. And again, homocystinuria, it is very important, as mentioned by our anesthetist Ravi sir, that anesthetic complication. So in all ectopia lentis cases in our hospital, we do serum homocysteine level to rule out this disorder and anesthetic complication. It is a rare syndrome, and more often we will encounter microspirophakia. So mild subluxation, we can manage conservatively: refractive error, anisometropia management, amblyopia. We have to remember it is progressive. It may be progressive, so we have to follow up. Moderate, we may say when it comes up to the midline of the pupil. So numerous concerns, diplopia, lens-induced aberrations, both hyperopic and myopic shadow will be obtained in the retinoscopy. So there are two options now. We can save the bag or go for lensectomy. How to save the bag? We can have modified Sioni capsular tension ring implantation. This video recently published in IJO video February issue. I have just fast forwarded for the want of time. And Rexis is the key important thing. And one can choose Sioni ring either of two designs are there, right and left design. It will have a tiny offset that Sioni hook will have. So it is quite easy to flip the ring and insert. So the orientation is very important. And to keep everything under conjunctiva, I have made that scleral groove after opening the conjunctiva and after passing this is two similar cases, but introducing different Sioni type ring. So we have to take care which end has to go first based upon the orientation of the Sioni CTR. It's quite easy. The question marks kind of sign should be there if we look from this side. That's the key thing. And this particular clip I wanted to show to tackle the sub-incisional rhexis, because rhexis is very important. We can go to the opposite side and make a paracentesis and introduce micro instrument to pull the rhexis and complete the rhexis. And even we can go for Hoffman pocket in case of grown-up children. And it is important to mark the Hoffman pocket so that the needle when we pass will go into that. Yeah, just wanted to show this thing so that we will pass the needle into that. And vitrectomy, whenever needed, we have to do. Most often it is not required. Pediatric vitreous will be very good, particularly more younger children. And here is our data where average age our age range is 4 to 20 years and 19 eyes. We have seen all kind of subluxation, and that 7 cases required capsulotomy, and the best visual median value is 6/9 in the last follow-up, and average follow-up is 22.5 months. And again, in literature also, there is good result mentioned in 3 years outcome. This clip is just to show the CTS. Here, being an aniridia case, we can understand how much the CTS tamponates, how many clock hours. And again, CTS we can use instead of CT Sioni when we want to introduce through the device through the side port, small side port, because it is being introduced through nasal aspect. Now we can see that bag is dipping down. So in such case, instead of iris hook, we can use even CTS to pull and stabilize the bag and lead into the bag and place the IOL. So advantage of bag conservation is lower rate of vitreous prolapse and lower rate of retinal detachment. So even literature says sutured scleral fixation shows 30% of breakage and dislocation of IOL in Marfan syndrome patient. Vasavada et al. Had mentioned 13% of decentration with the Sioni CTR implantation. At least in Sioni CTR, decentration is more common than dislocation, which can be resutured. So disadvantage of bag conservation, PCO, and though CTR delays PCO formation, YAG capsulotomy can be done. And gross subluxation can lead on to hyperopic shift. But even then we have to remove the lens, because the lens can dislocate into vitreous and cause complication, or positional angle closure and glaucoma can occur. Lensectomy, when there is gross subluxation, it is no other choice. If it is more than half the diameter of the cornea, it has climbed up. So in the lensectomy, the important thing is we have to make a small opening, at least partial rhexis or complete rhexis. Usually it is our practice, start by my mentor, Dr. Meenakshi Madam, that rhexis we practiced in the lensectomy cases. Yeah. So that it was useful in other ectopia lentis cases to make rhexis properly. And lensectomy, less surgical time, we can give some time for stabilization of IOL power and go for secondary IOL later. And post-operative care after lensectomy is anisometropia management by contact lens and amblyopia management. Where secondary IOL can be in the form of iris claw IOL, come in 2 different companies, and or iris fixation IOL. And scleral fixation, there are numerous techniques have been published, and but the thing is long-term follow-up in pediatric patient is the issue. I like to conclude based on this article, like outcome of 3 surgical procedures are compared here. One is Sioni CTR, another is sutured scleral fixation, another one is intrascleral fixation of IOL. So finally, they have concluded all the 3, so no significant difference in the postoperative result and complication. So one, as it is a surgeon's comfort, one can choose either of the procedure and treat patient accordingly. Thank you so much.
Yeah, wonderful talk. Wonderful. You try to do so much in the 7 minutes, but just one question. You can't do a primary posterior capsulotomy because you put a Sioni ring and or a CTS. So I suppose because these capsules can opacify also fast. So does it make sense to conserve the capsular bag at the intent of protecting the posterior segment, or would you
Yes,
think?
madam. Yes, madam. In our experience in this 21 eyes, PCO occurrence is delayed up to 2 years, probably because of the CTR placement. The CTR in the bag probably delays the migration of the lens equator epithelial cells into the center. That would be, we were worried initially to do many number of cases with this technique, but luckily we are able to manage 1.5 to 2 years only the children require. Even we do YACAP only, even at the mild stage of opacification, we don't allow for thick so that we will not give more distraction to the CONE. So that is the good point in that.
Thank you.
Fathima, do you like encounter decentration after YACAP?
No, madam, no. We have done 7 cases. Lucky, fortunately, we will do very cautiously and I mean in a low energy, and that's why prefer doing in the low mild opacification itself, not allowing for a thicker opacification.